Bismillahirrahmanirrahim. Assalamu alaikum. So today our topic is the vascular supply of the anterolateral abdominal wall. Now first we are going to study the arterial supply of the anterior abdominal wall, and then we are going to study about the venous drainage of the anterior abdominal wall. So about the arterial supply of the anterior abdominal wall, the anterior, or you can say anterolateral abdominal wall, is actually supplied by 3 superficial arteries and the 6 deep arteries. Now the 3 superficial arteries that are supplying the anterior abdominal wall are the branches of the femoral artery. That means the femoral artery is giving rise to the superficial arteries of the anterior abdominal wall. Now the first branch is the superficial epigastric artery. Then we have a second branch, that is superficial external pudendal artery, that is towards medial. And then we have the superficial circumflex iliac artery, that is towards the iliac crust or anterior superior iliac spine. So these superficial epigastric artery, that is going towards the epigastric part. Then we have the superficial external pudendal artery, that is towards the medial part. And then the superficial circumflex iliac artery, that is towards the lateral wall. These are the superficial branches or superficial arterial supply of the anterior abdominal wall. Now let's study the 6 deep arteries of the anterolateral abdominal wall. So first, these deep arteries are divided further into 3 categories. Now out of these 6 deep arteries, the 2 are coming from above, 2 arteries are coming from below, and the 2 arteries are coming from the side. Now let's study with the above. Now the 2 arteries coming from above are the branches of actually the internal thoracic arteries. That means they are originating from the internal thoracic artery. And now these 2 branches are superficial superior epigastric artery and the musculophrenic artery. Now let's study the superior epigastric artery in a little detail. That is, superior epigastric artery is one of the terminal branches of the internal thoracic artery, and it enters the upper part of the rectus sheath. Okay, it enters the upper part of the rectus sheath between the sternum and the costal origins of the diaphragm, and then it descends behind the rectus abdominis muscle in the rectus sheath and supplies the upper central part of the anterior abdominal wall. That means it is supplying the upper central part of the anterior abdominal wall, and it also anastomoses with the inferior epigastric artery that is coming from the below. Now the next 2 arteries are coming from below, and that are the branches of the external iliac artery. Okay, now these 2 branches are actually inferior epigastric artery and the deep circumflex iliac artery. So these are in turn branches of the external iliac artery, and they are coming from below inferiorly. Now let's study about the inferior epigastric artery in a little detail further. That the inferior epigastric artery is a branch of the external iliac artery, as we already studied, and it originates from the external iliac artery just above the inguinal ligament. It runs upward and medially. Now remember, it runs upward and medially along the medial side of the deep inguinal ring. And the deep inguinal ring we have already studied in the transversalis fascia part, that it is a, you can say, hollow cavity that is giving the passage to the spermatic cord in the transversalis fascia. That is a hollow space in the transversalis fascia, and that is actually called the deep inguinal ring. So it runs upward and medially along the medial side of the deep inguinal ring, and then it pierces the transversalis fascia to enter the rectus sheath. Now in rectus sheath it passes actually anterior to the arcuate line, but it descends again behind the rectus, behind the rectus muscle. And then because the same superior epigastric artery is also in the rectus sheath and coming downward inferiorly behind the rectus abdominis, it is actually ascending but also in the rectus sheath and behind the rectus abdominis. So eventually they are going to anastomose with each other. Okay. So there is an anastomosis between the internal thoracic artery and the external iliac artery. That means the internal thoracic artery and the external iliac artery are connecting to each other via the superior epigastric artery and the inferior epigastric artery. And we have already studied or discussed this point when we were discussing about the functions of the muscles of the anterolateral abdominal wall. So if you haven't taken that lecture, I will recommend or suggest you to immediately take that lecture or this lecture. Okay. Now the next part is about the deep circumflex iliac artery. So the deep circumflex iliac artery is a branch of the external iliac artery, and it also originates just like inferior epigastric artery above the inguinal ligament, and then it runs upward and laterally. So it is going, that means it is going laterally towards the anterior superior iliac spine just above the inguinal ligament, and then it continues along the iliac crust of the iliac bone, and there it supplies the lower part of the lateral part of the abdominal wall. That means it is supplying the lower central part of the abdominal wall, inferior epigastric artery. Superior epigastric artery supplying the upper central part of the anterior abdominal wall, and the deep circumflex iliac artery, as it is going laterally toward the iliac crust and the anterior superior iliac spine, so it is going to supply the lateral part of the lateral lower part of the anterolateral abdominal wall. Then about the two arteries that are from the side and that are actually from the aorta. But now the posterior intercostal arteries are actually the branches of the descending thoracic aorta, and the lumbar arteries are actually the branches of the abdominal aorta. That means we are actually differentiating them on the basis of their origin. The posterior intercostal arteries are actually originating in the thorax part. That's why we are saying that they are originating from the descending thoracic aorta. And the lumbar arteries are actually originating in the abdominal part. So that's why we are calling that they are actually the branches of the abdominal aorta. But now the posterior intercostal arteries are there are actually a lot of posterior intercostal arteries. Now actually the lower two posterior intercostal arteries are going to supply the abdominal wall. Only the lower two posterior intercostal arteries. And about the lumbar veins, we have the lumbar arteries. We have the four lumbar arteries that are supplying the abdominal wall, and they actually pass forward between the muscle layers, both these arteries, and supply the lateral part of the abdominal wall again. Okay. Now about there is some I have some key point about the inferior epigastric artery, and it says that inferior epigastric artery is actually further dividing again into two branches. Now it has two branches. One is the pubic branch and the second one is the cremasteric branch. Now the pubic branch of the inferior epigastric artery actually anastomoses with the pubic branch of the obturator artery. That means this pubic branch is connecting the inferior epigastric artery with the obturator artery, and in some clinical conditions this pubic branch may enlarge and replace the obturator artery, and in that case this pubic branch is called the abnormal obturator artery. Now what is the clinical importance? Actually this pubic branch is related to the femoral ring. Now how it is related to the femoral ring? Because we have discussed about the inferior epigastric artery that is actually passing medially with the deep inguinal ring, and with the deep inguinal ring we also have the femoral ring in that part, and so it is related to the femoral ring. And in the operations of the femoral hernia is actually the hernia of the femoral ring, this artery is prone to damage and it can be injured, and it can lead to the severe bleeding during injury. So surgeons have to keep in mark this branch of the inferior epigastric artery. Now about the second branch of the inferior epigastric artery, it is the cremasteric artery, and the cremasteric artery is actually passing through the deep inguinal ring, and it is going to supply the cremasteric muscle which is surrounding the spermatic cord. That's why it is passing through the deep inguinal ring. Okay, so that was about the arterial supply of the anterolateral abdominal wall. Now the veins of the anterolateral abdominal wall are again divided into two categories, same as the arteries. Like first we have 3 superficial veins, and then we have 6 deep veins. So let's start with the superficial veins. Now the superficial veins of the anterolateral abdominal wall are going to drain into 3 sides. Now the first, superiorly they are going to drain via the lateral thoracic vein. So the lateral thoracic vein is going to drain into the axillary vein. So the superficial vein of the anterolateral abdominal wall is the lateral thoracic vein. And then from inferiorly it is going to carry its drainage via the superficial epigastric vein. So the superficial epigastric vein is then going to drain into the great saphenous vein, and then the great saphenous vein, you all know, is going to drain into the femoral vein. So the superiorly it is going to drain via the lateral thoracic vein, and inferiorly it is going to drain via the superficial epigastric vein. Now there is an important point, and that is about the anastomosis of the axillary vein with the femoral vein via the lateral thoracic vein and the superficial epigastric vein. So lateral thoracic vein anastomose with the superficial epigastric vein to form the thoracoepigastric vein. And this thoracoepigastric vein is formed as a result of the anastomosis. Actually, it is an anastomosed vein that is formed by the result of anastomosis between the lateral thoracic vein and the superficial epigastric vein. But this thoracoepigastric vein is actually providing another channel for the venous drainage of the abdomen and you can say of the body. So the thoracoepigastric vein, this vein actually connects the axillary vein with the femoral vein. So that means it is going to provide an indirect pathway. Now this anastomosis of this vein, that is the thoracoepigastric vein, I said it is very important, and it is serve as a second channel in case of the superior vena cava obstruction. So when there will be superior vena cava obstruction, then this vein will be dilated. So if this vein is dilated, that means the thoracoepigastric vein, if we see that this vein is dilated, then we will suppose that then we will diagnose that there is clearly an obstruction in the superior vena cava. So this is important clinically. Now let's move to the third vein, that is about the paraumbilical veins. So now we have studied the drainage from the superficial and the inferior part, but now from the medial part they are going to drain via the paraumbilical vein, and these paraumbilical veins are actually going to drain into the portal vein. So let's have an overview of all these veins, superficial veins of the anterolateral abdominal wall. So the superficial veins form a network that radiate out from the umbilicus. Now above the network drains into the axillary vein via the lateral thoracic vein, that means superiorly it is going to drain into the axillary vein via the lateral thoracic vein, and below into the femoral vein via the superficial epigastric and the great saphenous vein. So that means the superficial epigastric vein is going to drain into the great saphenous vein, and then finally the great saphenous vein is going to drain into the femoral vein. And a few small veins, the paraumbilical veins, connect the network through the umbilicus and along the ligamentum teres to the portal vein. That means these short paraumbilical veins are actually radiating out from the umbilicus, and then they are going to follow along the ligamentum teres. We have studied the ligamentum teres in the embryology of the abdomen, and also in the peritoneum we will study the ligamentum teres in the peritoneum. And then while following the ligamentum teres, these paraumbilical veins are going to drain into the portal vein. So this actually forms an important portal systemic venous anastomosis. So here the portosystemic venous anastomosis is actually forming. Okay. So that was about the superficial drainage of the anterolateral abdominal wall veins. Now let's talk about the deep veins of the anterolateral abdominal wall. So we have actually 6 deep veins that are going to drain the anterolateral abdominal wall. First we have the superior epigastric and the musculophrenic veins, just like the arteries. Just remember the concept of the deep arteries, and then if you remember the deep arteries, then you are correspondingly going to remember the deep veins of the anterolateral abdominal wall. So first we have the superficial epigastric and the musculophrenic veins. So these phrenic veins are actually going to drain into the internal thoracic vein, we already know. Then we have the inferior epigastric and the deep circumflex iliac veins. Sorry, this is superior epigastric vein, not superficial. And then we have the inferior epigastric and the deep circumflex iliac veins, just like in the artery section we have studied, and these are again going to drain into the external iliac veins. And then we have the posterior intercostal veins, but now posterior intercostal veins are not going to drain into the superior vena cava like that in the section of the arteries that were actually draining into the aorta, but here they are going to drain, the posterior intercostal veins are going to drain into the azygous vein. And about the lumbar veins are going to drain into the inferior vena cava. So these were actually the 6 deep veins of the anterior abdominal wall. So what we studied, that the superior epigastric and the musculophrenic veins, these are going to drain into the internal thoracic vein. The inferior epigastric and the deep circumflex iliac veins that are coming inferiorly are going to drain into the inferior external iliac vein. And then the posterior intercostal veins and the lumbar veins from the sides are going to drain into the azygous veins and the inferior vena cava respectively. Now let's study about the anterolateral abdominal wall lymph drainage. So the lymph drainage of the anterolateral abdominal wall is again divided same as the arteries into the superficial and the deep parts. So let's study the superficial part. So superficially, above the level of umbilicus, the lymph drainage of the skin of the anterior abdominal wall is going to drain upward into the anterior axillary, that are the pectoral group of lymph nodes. They are called the pectoral group of lymph nodes. They are because they can be palpated just beneath the lower border of the pect major muscle. And below the level of umbilicus, the lymph drains downward and it is going to laterally drain into the superficial inguinal nodes. Okay, so the above the level of umbilicus into the anterior axillary group of nodes, and below the level of umbilicus they are going to drain into the superficial inguinal nodes. Now about the lymph of the skin of the back, that above the level of iliac crust is drained into the posterior axillary group of nodes. Anterior axillary group of nodes above the level of umbilicus, posterior axillary group of nodes posteriorly but above the level of iliac crust. Now posteriorly, below the level of iliac crust, they are going to drain into the superficial inguinal nodes, same as for that for the below the level of umbilicus. Now about the deep lymph drainage of the anterolateral abdominal wall, so they are in correspondence with the deep arteries of the anterolateral abdominal wall. They follow the arteries and then they are going to, like that arteries, they are going to drain into the internal thoracic lymph nodes, external iliac lymph nodes, posterior mediastinal lymph nodes, and para-aortic, that are the lumbar lymph nodes respectively. Now let's study some clinical notes related with our topic. So before starting, let's know why are these clinical notes important. Now you already know the abdominal wall contains many superficial veins and lymphatic vessels. Now normally what happens, that blood flow easily back to the heart and the lymph flows to the nearby lymph nodes. But when a major vein becomes blocked or when the portal hypertension develops, these superficial vessels become alternate pathways, or you can say collateral pathways. That's why they become enlarged and visible. Now the first clinical note is about the caval obstruction. So let's start. But before starting, first ask yourself a question. What is the vena cava? There are two major veins returning blood to the heart, as you already know. One is the superior vena cava that drains upper body, and the other one is the inferior vena cava that drains lower body. Now imagine a highway. If the highway is blocked, cars don't disappear. They take side roads. Okay? Exactly the same thing happens with the venous blood. That means if the vena cava blocked, the blood is going to take some side roads, and that are called collateral. Now normally what happens, that from the legs the blood drain into the inferior vena cava and then it is going to drain into the heart. But what happens if inferior vena cava is blocked? Blood cannot move upward through the inferior vena cava, so it looks for another route. So it uses superficial veins on the abdominal wall. Now what is the route? Actually the blood is going to drain through the femoral vein, then it is going to enter the superficial epigastric vein, and then from the superficial epigastric vein it is going to enter the thoracoepigastric vein. Then from the thoracoepigastric vein it is going to enter the lateral thoracic vein, and from the lateral thoracic vein it is going to enter the axillary vein, and this axillary vein is going to drain into the subclavian vein, and we all know subclavian vein directly drains into the superior vena cava, and then it indirectly reaches the heart. So what happens, that via the thoracoepigastric vein, that is actually anastomosis between the superficial epigastric vein and lateral thoracic vein, the blood gets an alternative pathway in case of inferior vena cava is blocked. Now notice something, blood bypassed the inferior vena cava completely. That is why these superficial veins become large and tortuous, that is called the varicose vein. These tortuous veins are called the varicose vein because they become enlarged because all the blood passes through this. Now why does the book mention the thoracoepigastric vein? Because it is the bridge between the superficial epigastric vein that is connected to the femoral vein or inferior vena cava and the lateral thoracic vein that is connected to the axillary vein and the superior vena cava. So these veins form an important caval anastomosis. Think of it as connecting a road between two highways. Okay. Now the next clinical is about the portal vein obstruction, that is also called the portal vein hypertension. This is completely different. Now the problem is not the vena cava. Okay, the problem is the portal vein here. Previously the problem was in the inferior vena cava, but in portal vein obstruction the problem is in the portal vein. Okay, now what does the portal vein do? We all know that it carries blood from the intestine, stomach, spleen, pancreas to the liver. Okay, so intestine, from the intestine the blood is entering the portal vein, and the portal vein carries the blood to the liver, and from the liver via the hepatic vein it is going to drain into the inferior vena cava, and then it drains into the heart. That is the normal route. Now what happens in the liver cirrhosis? Scar tissue forms. Okay, when there is a cirrhosis of the liver, there will be a formation of the scar tissue. Blood cannot pass easily through the liver, pressure increases. This is called the portal hypertension. So portal vein obstruction usually occurs because of the portal hypertension caused by the liver cirrhosis. Remember. Now where does the blood go? That is the question. So again, blood finds another pathway, because blood has to drain into the heart. If the one route is blocked, it is going to take another pathway, just like the highway roads. Okay, now one important site is around the umbilicus. We already studied their portal system. We have the around the umbilicus we have the paraumbilical veins, and these paraumbilical veins actually communicate with the systemic veins, that are the superficial epigastric veins. So this communication is called the portosystemic anastomosis. We already have studied about this when we were discussing about the venous drainage of the anterolateral abdominal wall. I mentioned the word portosystemic anastomosis. Now the book has mentioned a word caput medusae. Now what is this? Because pressure is very high, in the liver, the superficial veins around the umbilicus enlarge, they radiate in all the directions. Okay, now this resembles their radiation that resembles the snake hair of the Medusa in Greek mythology actually. So hence the name is given the caput medusae, that is like the head of Medusa. That is actually the resemblance that it resembles with the snake hair in the Greek mythology. That's why it is called the caput medusae. So okay, that's why the figure C is showing. We can see in the figure C. Here you can see they are actually radiating from the umbilicus in all the directions, like they are just like resembling the snake hair of the Medusa. That's why it is called the caput medusae. So what are the possible Viva questions about the clinical notes that can be asked? So the first question can be, why do the abdominal veins become dilated in the inferior vena cava obstruction? So your answer can be simply because blood cannot return through the inferior vena cava because of the obstruction. So it is diverted through the superficial abdominal veins, especially via the thoracoepigastric vein into the superior vena cava, and that produce the dilated collateral veins. Okay. Now what is caput medusae? The second question can be this. So the answer is caput medusae is the radiating dilatation of the superficial veins around the umbilicus due to the portal hypertension that is commonly caused by the liver cirrhosis. Here, this is the caput medusae. We already see. Now, what is the second question can be, what is the anatomical basis of the caput medusae? So, the caput medusae, it results from the dilation of the portosystemic anastomosis between the paraumbilical veins, that is the portal system veins, and the superficial epigastric veins, that are the systemic veins. Okay. So that was some clinical Viva questions related with the clinical notes of this topic. That was all about the vascular and the lymphatic supply of the anterolateral abdominal wall. Thank you so much. Allah Hafiz.